The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, and good evening, depending where you are. My name is Juliana, and on behalf of ISQua, I'm delighted to welcome you all to today's webinar. And the webinar today is on why applying human factors and ergonomics is important to patient safety. Our presenter today is Agnès, who currently works as a team leader of Global Capacity Building and Education in Safety and Quality of Service Delivery for World Health Organization. She also leads the programs for standardization in patient safety solutions, patient safety education, and global capacity building in patient safety. Since her appointment at WHO headquarters in Geneva in 1998, she has led projects for several WHO programs, including communicable diseases and health systems. She serves as chair in several patient safety global committees. Agnès' background has been in medical research, lecturing, and directed projects related to campaigning of health programs within European and developing countries. She has authored 70 peer reviews and non-technical papers and served as managing editor of 12 WHO reports. Agnès has a PhD in biomedicine and biochemistry and 20 years experience in global public health. Just to remind you that Agnès' presentation will take approximately 45 minutes and we will leave 10-15 minutes for any questions that you may have at the end. Please type your questions in a question box provided and we will do our best to get them all answered at the end. We will bring some interactivity into this webinar by means of using polls during this session. Therefore, we kindly ask all the attendees to take an active part by responding to the polls questions. I hope you will enjoy this presentation, and over to you, Agnès.
Thank you very much, Juliana. Good morning and good afternoon, ladies and gentlemen. We are delighted to be able to participate in this webinar that has been hosted and organized by ISQua. I'm going to be talking about human factors and why applying human factors is important for patient safety. This presentation will focus on these 5 areas primarily, and the first one is really what is human factors engineering or ergonomics. What does human factors engineering involve? Application of human factors knowledge in healthcare with specific focus on safety, on patient safety. What is misperceptions and how they link with human factors and how they link with the delivery of unsafe care? And finally, factors that predispose us to error. First of all, what does human factors mean? Now, the study of human factors is a very well-established science that uses many other disciplines such as psychology, anatomy, physiology, neurosciences, biomedicine, etc., to examine the relationships that exist between humans and the systems they interact with. It can apply anywhere, wherever people work, and of course it applies within the healthcare facilities and in the healthcare sector. We know from evidence that failure to apply human factors principles can harm patients. And it is the study of factors that make it, human factors that make it easier to do work in the right way. Now, human factors has been called invariably I beg your pardon, Human factors has been called various names. One of them is human factors engineering, the other one is ergonomics, the other one is systems engineering, user-friendly systems, some call it designer systems. These terms are very, very similar, and what they encapsulate is that this wording is used to describe interactions that take place between individuals at work, the tasks and the job they have to do, and the workplace environment. So if we visualize the individual and his or her competencies, with the task that this individual has to do within a proper environment, when these three are linked and working harmoniously, the work is progressing normally. However, if one of these three elements is not harmoniously linked with the other, then there is a high potential to have an accident. And this is what we are witnessing in healthcare, and we are seeing how human factors predisposes us to making errors and the unsafe delivery of care. Now, the second point here is, what does human factors involve? As we said previously, human factors is a discipline that seeks to optimize the relationship between technology, humans, and the environments they operate in. It uses and it applies information about human behavior, about human cognitive abilities, about human limitations in order to design tools properly, in order to design equipment which is user-friendly, in order to develop systems and tasks and environments that are effective and comfortable and safe for human use. For safe human use meaning healthcare providers' use, so they're able to deliver safe and high quality care. An important point here is about human cognitive skills and hence their decision-making capacity that are affected by challenging healthcare environments. We all know about the very busy, very chaotic healthcare environments, and that can have a negative impact on human cognitive skills, and hence that can affect the quality and the quality of the healthcare they're delivering. Now, human factors, the links between human factors are human-machine interactions, and these really relate to humans, to healthcare providers operating equipment or using tools. So therefore, the tools and the equipment must be designed so that they're easy to be used by healthcare providers. The second link is human-to-human interaction, and this involves provider to provider or provider to patient, and primarily focuses on communication and effective teamwork. It is human factors that affect communication. When humans have difficult and complex tasks to do, then their communication with other members of the healthcare teams is affected. So if we take human factors into account, then we can improve communication between providers. Finally, it's the human-environment link, and this seeks to find the best fit between people, in other words, healthcare providers, and the workplace in which they operate in. Why is the issue of human factors in healthcare important? So we've talked about, I would like to summarize what we've talked in the previous slides. First of all, that human factors are major contributors to adverse events, and there is evidence on that. And in order for healthcare to be made safer, we need to develop systems and tools and the right environments so that healthcare providers can operate in an effective, safe way. Now, the knowledge of human factors can help us develop user-friendly characteristics in the design of tools, such as, for example, scalpels or syringes. Nice and well-developed systems that, for example, take information about patients, electronic patient records, or develop appropriate computer order entry systems or programs to support the dispensing of drugs. This knowledge helps design environments for effective and comfortable use, and what we mean by that is a good layout of the wards, that the lighting is properly in the work areas, that the nursing stations are developed and constructed properly, the labs as well, and also it even goes to well-designed beds, particularly when we're looking at the elderly patients. Finally, develop equipment that minimizes the likelihood of errors, for example, designing IV pumps or defibrillators that are intuitively and user-friendly to use. Now, I will give you some examples of human factor weaknesses and how these contribute to unsafe care. For example, when patients receive incorrect medication or treatment because of look-alike medication packaging and names. I will show you some examples of that in the slides to come. Another example is when healthcare staff incorrectly identify a patient because he or she has the same or similar sounding names as someone else. Another example is when a nurse ignores the critical alarms because there are so many forms of alarms in wards or ICUs, she has become completely desensitized to this. Or when a junior doctor is called in the middle of the night and he's very, very tired and he's very sleepy and he's called to care for a patient, and the next morning he or she do not remember having seen a patient or what the patient order has been. So let's go to some examples here. How do human factors apply to healthcare? Is there a problem with this slide? We see the note nil by mouth, and there's the nurse giving breakfast to this patient. So obviously there is a problem here, and the problem is linked to systems, to poor systems. The problem is linked to poor communication, so that the nurse gives breakfast when she clearly sees the sign nil by mouth. Another one is an example of look-alike heparin vials. There have been many cases of deaths, neonate deaths particularly, and injuries, because although they're differently colored, these two vials, they look quite similar, and of course they hold different concentrations. One of them is 10 units per mil of heparin, and the one next to it, the orange-looking one, is 1,000 units per mil of concentrated heparin. Now, in a particular case in a hospital in the US, these vials were accidentally placed in the same automated dispensing cabinet that normally would hold 10 units per mil vials. So the nurse accidentally took, without checking of course, the 1,000 units per mil vials, and they injected them. So you can see how look-alike vials, or the branding, which is very look-alike, can cause problems. And this is really a human factor issue. Another example here of look-alike, sound-alike medications, this particular one is look-alike. Both of these preparation solutions, one of them is called tropicamide and the other one is called cyclopentolate. They're both anticholinergic and they're both used for dilating the pupil. The second one is for pediatric use. And it's, you can see where mix-ups can happen because they're so similarly looking. Another example that we talked in a previous slide is about having the right environments in the wards or the nursing stations that prevent unsafe care from being delivered. And this involves cluttering, this involves incorrect lighting, etc. You can see in the top row, you can see a ward which is very badly lit with one bed next to another. You can see in the photograph below another ward which is well lit and it's clean, it's spacious, and you can see that there is good interaction between healthcare providers and patients. With regards to the nursing stations next to it, you can see one nursing station cluttered, you have some medication behind, while the one designed below has a well design which is good for use by healthcare providers. Another example is the design of defibrillators. Here you will see two not so good examples of defibrillators where there is a lot of wiring, buttons are not very clearly labeled, while if we see this defibrillator, there's two buttons there, the number 2 and number 3. Number 2 is charge and very clearly number 3 is discharge. You can see it in the enlargement. So the design of this defibrillator is a user-friendly design that contributes towards not making errors by pressing an incorrect button. And we should not really forget that healthcare is a very, very complex environment, and just the complexity hugely contributes to human factors issues and a predisposition to making errors. So, finally, is it possible to manage human factors? Yes, it is very much, and we can see it in other industries. Management of human factors involves the application of methods or development of systems that aim at minimizing errors or learning from errors and near misses. We have already seen it in various other industries, aviation, military and manufacturing. Aviation is an industry that has made use of human factors principles in order to move towards a culture of safety since the mid-1980s. And by using human factor principles, the aviation industry has managed to improve the situations and the environment which pilots, for example, operate, and they have reached records, high records of safety. Since 1965, the aviation safety record has been impeccable, really. With an average of 10 million flights per year, there have been very few fatal crashes worldwide in commercial aviation, and many of these crashes have occurred mainly in developing countries. So I would like to show you a film that really demonstrates the importance of human factors within surgery and OR.
Years ago, doctors at Mayo Clinic in Rochester, Minnesota opened the doors to modern open-heart surgery using the heart-lung machine. Back then, you had about a 50-50 chance of making it off the table. Now you can be 98% certain that you'll survive. But doctors at Mayo Clinic say that's not good enough. They're using methods developed by the aeronautics industry to make surgery even safer. Air travel is very complex, but very safe. A main reason for this high level of safety is the time and research the industry put into designing technology that's user-friendly. For example, everything the pilot needs is at his or her fingertips, and he or she can communicate with the crew at any time. This design makes it less likely for the pilot to make errors. Such highly tuned orchestration grew out of an aeronautics discipline called human factors.
They developed approaches to dealing with the complexity of the aircraft, like checklists, to help the human cope with this very complex machinery.
And that's what Surgeon Thorolf Sant hopes to do in the operating room.
What human factors brings to us in the operating room is trying to understand how to prevent errors in medicine. If an error occurs, how to capture it quickly before any harm is done.
Dr. Sant is teaming up with quality care expert Sarah Henriksen on a study to see if observing what happens in the OR can help them understand how to make the process better and safer. You can see how the camera used in the study may have caught an area where communication could have been improved between the surgeon and the perfusionist. He or she is the person who runs the heart-lung machine, which is a very complex piece of equipment.
So I may give a command here. I'm actually faced away from the perfusionist. They can't see my mouth. They can't read my lips. And I'm talking down into the wound.
So perhaps rearranging where people stand could improve communication.
And we think that there's a lot that we can learn by watching how the team functions.
Making surgery safer for those who put their lives in their medical team's hands. Dr. Sant says some of the other issues that he noticed from observing how his operating room functions include distractions caused by beepers going off and people walking into the room. He hopes to use the information from the study to make operating rooms safer and more efficient. He also says that by encouraging other members of the surgical team, such as nurses and technicians, to speak up if any issues arise, will add safety in the OR. For Medical Edge, I'm Vivian Williams.
So, let's move to a related subject, and this is about perception and misperception, which is very, very relevant to human factors issue. So what is perception? Perception is processed through the 5 senses, the sight, hearing, taste, touch, smell, and it is an input process of information that comes into our brain from our environment. What is misperception? Is to understand or perceive incorrectly, not to be able to distinguish, to detect, to discern, to differentiate. And these things are very, very relevant in the healthcare context. Now, why we cannot distinguish or detect, discern, and differentiate? Two main reasons. There could be an underlying medical problem, or it could be poor concentration and attention deficit. So let's look at the difficulties in being able to concentrate. What this means is a decreased ability to focus on something. Now, concentration difficulties relate to anxiety, stress, mood disorders, difficulty staying awake after having sleepless nights in the wards, impulsiveness, fatigue, again for the same reason, intrusive thoughts or concerns that we may be having of personal nature, overactivity or inattention. Concentration difficulties can be caused by medical, cognitive or psychological problems, or may be related to sleep problems or medications, alcohol or use of drugs. Now, I would like to turn this over to Juliana and ask the audience, what is this, one or two vehicles? What can you see in this slide?
The audience is voting at the moment, so we'll just wait a tiny bit longer to see what the results are, and I'll display them on the screen. Okay. It looks like, let's just display the results. And the results that 64% could see one vehicle and 36% saw two vehicles. Over to you, Agnès.
So this is very interesting because indeed what is happening here is that, oops, I think we have. What is happening here is that indeed the majority spotted it right. It's one vehicle, which is the van, and on top of it there's a green vehicle that is being painted. Now here it's clearly an issue of attention. We have paid attention to this and we have managed to discern that indeed there is one vehicle with another vehicle painted on top of it. But if we are in a very, very busy environment, chaotic, and we are running around to do millions of things, and our eyes just glance that, we will just see two vehicles. So this is an example where attention within a healthcare environment plays a very, very important role, and not focusing or not having attention on a situation that is developing in front of us can have a bad impact, can give us wrong information, and can make us prone to making an error. So another type of misperception is the auditory one. What did you hear? Now consider the example of a pharmacist who is taking a medication order over the telephone and is interrupted by one of his colleagues asking a question. The pharmacist may mishear the person on the other end of the phone, or fail to check the medication or dosage a second time after it was said to him over the phone as a result of the distraction. Now, what did the pharmacist hear? Did he hear clonidine, which is a drug to treat high blood pressure, or did he hear clonopin, which is a trademark for clonazepam? Did he hear 100 micrograms, or did he hear 100 milligrams? So, here we have an auditory misperception because of an interruption. What do you remember? This is a typical scene of a complex OR room. What I would like to ask you here is to try and memorize what is in this picture and to try and recall as many details as possible. So if you please can take 30 seconds to look carefully at this picture and try and remember what you have seen. Juliana, over to you so that you can run the poll. Juliana?
Agnès, we will give 30 seconds for the attendees to remember what's in that picture, and then we will display the next slide so they have the options which should be available for the next poll. So it's just going to take a few seconds.
Okay.
can you please move to the next slide and I will launch the poll. Agnès, thank you.
Thank you.
So the question is, what do you remember from the picture? Can you please make your choices? We have 60% of the attendees that have voted already, so just a couple of more seconds and I'll display the results. So as you can see that none of the items listed, we have 13% who voted for that, some of the items listed 60%, and all of the items listed 27%.
Thank you very much. Thank you, thank you. Let's go to the next slide. So the next slide lists again the items, and we have the picture of the OR. So the majority of the audience really spotted it right by saying that some of the items they identified. The reason is that in the items that we have listed previously, there were two that were not present. There was no endoscopy equipment and there were no surgical lights. But because we always know that ORs have surgical lights and endoscopy equipment, then our brain automatically incorporates these two items, and we thought that we had seen them while in reality they didn't exist there. Now, I would like to go to the next slide and talk about false memories in the workplace. And really, what the previous example demonstrated is that not everything we recall has actually happened. Emotional self-focus, distractions such as anxiety, for example, or stress, when trying to remember something, can decrease the accuracy of the memory without necessarily decreasing the memory of an event itself. Our brain can have false memories, like, for example, we thought we saw an endoscopy equipment and we thought we saw the surgical lights, remembering things that are not there or have not taken place. So in the last slides, what really highlighted is the visual misperceptions. If we don't focus our attention on something, we can visually misinterpret what we are seeing. We have witnessed auditory misperceptions, communication between providers, for example. Sometimes the information we receive tells us only half of the story. Therefore, hasty decisions can lead to errors. We tend to forget, not remember things, and also we tend to have false memories. Decisions and actions can be flawed. This is what this is telling us. Decisions and actions can be flawed. The fact that we can misperceive situations despite our most ethical and our best intentions is one of the main reasons that our decisions and actions in healthcare can be flawed, such as that things are perceived incorrectly and errors are made. In the context of healthcare, when errors occur, the consequences can be a problem for the patient with serious injury or even patient death. Now, this situation is particularly important and it's relatively unique to healthcare, where a particular professional error can lead to another person's injury or death, a patient injury or death. Let's talk about error by itself. James Reason, who is a father on these issues, he has defined error as the failure of a planned action to achieve its intended outcome, or as a deviation between what was actually done and what should have been done. Now, the relationship between human factors and patient safety with regards to error is exactly this point, that human beings make errors. Healthcare providers must be very mindful of this fact and the situations that increase the likelihood of errors. Regardless of our experience as healthcare providers, or our intelligence, or our good intention, or our ethical behavior, our motivation to save lives and to help everybody, or our vigilance, we do make mistakes. People make mistakes, and this is a fact here. So one definition of human error is that our human nature is that error is the inevitable downside of having a brain that can be under not normal conditions of functioning. And what I mean by that is the chaotic, the very busy, the very difficult environments that exist within the healthcare settings. But why? Now, a number of individual factors affect human performance, thereby predisposing us to making an error. And there are two main factors with the greatest impact, and one of them is stress and the other one is fatigue. Now let's just see stress. Just a minute because I can't move the slide. So here's the first one, stress, which can have a negative impact on performance and predispose to error. What we mean by stress is work-related stress and a massive workload, very challenging and difficult environment, trying to do our work in very cluttered and crowded environment with little lighting. We may have work difficulties. We may be dissatisfied with our work. We may have personal problems of the nature, financial, health, personal, of any nature. All these things can lead to stress when we are in the workplace. Now there's very clear evidence, there's been a lot of research that has been done linking stress and performance. So in this graph here we see the y-axis where performance is and the x-axis which is the stress levels. Doing our work properly because we're not focusing, we're not paying too much attention on the task that we have at hand to do. As the stress level increases, it reaches a point where there's an optimum area of stress where we are at the highest performance level. As the stress increases, then we see that our performance drops. And at high stress, we experience a lot of anxiety, we experience panic, we experience a lot of disadvantageous mental states that predispose us to making errors. The second one is fatigue, and that impacts performance also very badly. Fatigue reduces our decision-making ability. It prolongs response time when we have a particular task at hand to do. It increases lapses of attention. For example, we focus on a particular task and then our mind goes away and then it comes back. We've all witnessed that in our daily life when we are stressed or when we are panicked. It negatively affects short-term memory, our working capacity, our working memory. It is affected by fatigue. It lessens the ability to multitask. We know how healthcare providers have to multitask and the extent that they have to multitask. And fatigue impairs that. It increases, of course, irritability, moodiness, and depression. It decreases the ability to communicate properly and well. And going back to the previous graph that we saw, boredom coupled with fatigue can lead to sleepiness, which can also affect performance. Fatigue. Research has shown that 24 hours of sleep deprivation has performance effects, and this is equivalent to having a blood alcohol content of 0.1% in the bloodstream. Now, it is illegal to drive a car when we are intoxicated. However, it is not illegal to do our daily work in a healthcare facility, to operate, to see patients if we are very tired. So these two are very linked. We've talked about fatigue and stress, but there's other factors that predispose us to error, and this can be hunger. If we're hungry, we can't work well. We are very irritable. If we are ill, the same. If there's language or cultural factors involved between the interaction with patients or providers themselves, and also if we have hazardous attitudes. There are situations as well which are associated with an increased risk of error, and they're highlighted here. One of them is unfamiliarity with the task. If we are not trained well, we cannot perform something well, and this is a human factor issue, as is inexperience. The first two, if combined with lack of supervision, can have very detrimental effects. Another one is shortage of time. we have too many things to do in a healthcare environment, and healthcare staff are so busy they have shortage of time in doing a particular task or activity. This is a situation associated with an increased risk of error, as is inadequate checking. Poor procedures that are in place or are not in place by the healthcare facility, and poor human equipment interface. We have talked about that in previous slides. And this is something that has been put together by Charles Vinson. Now, the aviation industry, we've talked about this before, has been very forward-thinking in terms of putting checks in place that pilots or aviation staff are obliged to do before starting their work. And these are acronyms, the two ones I have here, and one of them is I am safe. So this is a personal check to see, do I have an illness? Am I under medication which affects my cognitive abilities? Am I stressed? Have I drunk alcohol? Am I very tired and fatigued? Am I very emotional? Because if any one or two of these parameters is in place, then perhaps I'm not in a good situation to go to a workplace and work. And also don't forget the other one, which is if I'm hungry, if I'm angry, if I'm late, or if I'm tired, this also has a detrimental effect. The second one, the initial, is halt, of course. Now, these checks that exist in the aviation industry, these self-checks that aviation staff are obliged to do, they do not exist in healthcare. So perhaps all healthcare providers should consider using a series of personal error reduction strategies to ensure that they perform optimally at work. So putting knowledge of human factors into practice, applying human factors thinking in the workplace, there are some quite easy tips to follow to limit the potential of making an error. And this is to avoid reliance of memory, and this is why protocols are very useful to have at hand, to be able to always refer to protocols. Making things visible, this is in the form of pictorials or illustrations of how to use equipment. A typical one, of course, is to have the workplace reminders on hand hygiene above sinks or in the wards, the importance of hand hygiene and the moments when to do hand hygiene. So this is making things visible, a visible reminder. Is to review and simplify processes, the third one. We know how complicated and how complex some healthcare processes are. It is really a very good thing to try and simplify them so that they are performed with minimal risk of error. The fourth one is to standardize common processes and procedures. We know that standardization contributes to safety. Then the fifth one is to routinely use checklists, and the use of checklists have been used a lot in aviation industry, but of course in healthcare as well. So checklists are a reminder of the things that are necessary to be done. And also increase vigilance, and what I mean by this is when healthcare providers do a mundane, repetitive job, their vigilance tends to decrease. So there's always we should always have a focus on keeping our vigilance at high levels. Now, is this enough? What is important is to take these important and useful and easy tips and practice them in simulation, in simulated healthcare settings, and to be able to see human factors at play, so to speak. I would like to finish with a graph here that clearly demonstrates that that obviously in the y-axis we have performance, and on the x-axis is time going by. And when we go in the morning at work, we see that our performance is 100%, and with the hours passing by, our performance increases. You can see here that in the first hour, performance drops to about 95%, and the second hour it drops below 90%. In the third hour it's about 80%. In the fourth hour it goes about 70%. Now the point about understanding and having knowledge and practicing the principle of human factors is to be able to move our deteriorating performance upwards by applying human factors engineering and the principles. So the conclusions of this presentation really are that errors are inevitable for any healthcare professional. Everyone misperceives. This is part of human nature. This is part of having a brain. Everyone misperceives situations. And there are issues, as we've talked before, with misperceptions, with memory, with attention, and with lack of concentration. There are situations as well that can cause, that have an increased likelihood of misperception, memory, false memories, and making errors, particularly stress and fatigue. Attention to human factors principles and human factors engineering can lead to a reduction in errors and its consequences. And this is what we have seen over the years with the aviation industry, and this is why aviation industry is considered one of the safest industries, because they really apply human factors principles. Now, managers and leaders have a key role to play in supporting the design of a workplace to accommodate for human limitations and human abilities, and to take into account the principles of human factors. Finally, stimulation and training is very important because it helps providers to practice these issues, to practice the important processes that promote quality and safety. Now, the benefits of human factors engineering in healthcare: we have more efficient healthcare processes, we can communicate more effectively between healthcare providers in healthcare teams, we have a better understanding of a patient's medical condition, we are able to communicate better with the patient and understand the patient better. We can implement more effectively the interventions that are and the tasks that are at hand. We can work and we can reduce the risk of device error, try and reduce fatigue and stress of a healthcare provider because of ergonomic design of the environment. And all this leads, of course, to cost savings through preventing and mitigating adverse events. Of course, we will have improved patient outcomes and improvement of service delivery by changing the education tools, by having simulation in order to practice human factors principles. And this is exactly what they're doing through simulations in the aviation industry. Now, this course or this presentation that I have made is part of WHO work that is presented in the Patient Safety Curriculum Guide. And this is the web link, the URL, I beg your pardon, in the WHO website where the curriculum guide can be downloaded. The course that I've been talking about, which is how human factors impact patient safety, is topic 2, and you can go to this link and download topic 2. I would like to finish with a film which is called Just a Routine Operation, which is presented by a pilot himself and a tragedy that has happened in his family.
My name is Martin Bromley. And this is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong. I'm an airline pilot with a background in human factors. I want to make a difference. I want to be able to say to Victoria and Adam in a few years' time that although their mum died, the lessons from that have been learnt, and that there is a change in practice in healthcare in the UK. Elaine actually had very good health, but she had suffered from some sinus problems, and as a result, a consultant had recommended that she should have routine sinus surgery. We left at 8:30 in the morning, having kissed Mummy goodbye, and went off to do the weekly food shop. I got a phone call at about 11 o'clock that morning from the ENT consultant, and they explained to me that when Elaine had been anaesthetised, her airway had collapsed.
that the oxygen levels in her body had fallen to very low levels. And so they decided that the safer option was to let Elaine wake up naturally. And unfortunately, she hadn't done so. I went across to the intensive care unit, and there I was met by 2 further consultants. They explained to me very bluntly that Elaine had been without oxygen for a significant period of time, and that I was looking at her having significant brain damage. Another brain scan was taken, and even to me as a layman, comparing the new scan with the benchmark scan, there was no doubt that by this stage there was virtually nothing that could be done for Elaine. And I made the decision in was that they would start with a laryngeal mask, and they had done a very thorough pre-op assessment. There were no undue causes for concern at this stage. And at 8:35 in the morning, Elaine was anaesthetised.
Off we go now. Off to sleep.
The first mask wouldn't fit. They tried a second mask.
Having problems here. Hold down a bit. Let me push the head back a bit more.
They then tried some extra drugs to try and reduce some suspected tension in the muscles in the jaw. So it was obvious almost straight away that things were going wrong. We know that 2 minutes in, Elaine's oxygenation was 75% and falling, and she was by this time already visibly blue. Within 4 minutes we know that her oxygenation had fallen to 40% or lower. There's some confusion about the precise time, but we know that 6 to 8 minutes in, a number of things were happening. The anaesthetist had already started to attempt to intubate Elaine. The oxygenation was still at 40% or lower, the heart rate was falling. The ENT surgeon waiting to perform the op came into the theatre. An anaesthetist from an adjoining theatre became aware of a commotion, and he walked in to see what could be done. And at least 3 nurses answered a call for help. And what happened is that the 3 consultants continued with the attempt.
Yeah.
15 minutes, the 3 consultants would appear to have continued with their attempts to intubate to the exclusion of any other option. And that at the end of that 15 minutes, we're now 25 minutes into the whole procedure, they eventually get Elaine's oxygenation to 90%, but she's actually been at 40% or lower for a total now of over 20 minutes.
We get above 90.
No, she won't go up.
No, you got 90 though.
That's better.
I don't think we should carry on with the operation.
No, I agree. I think we should abandon this stage.
Okay.
The airway itself is not secure though, and so they fiddle around a bit more, and in fact her oxygenation falls again below 90% for a further 10 minutes, and finally by the time we're 35 minutes in, they seem to make the decision that the best thing is just to let her wake up naturally.
Let's wheel her back quick as we can.
And they transfer her to the recovery room. She lays there for an hour and a half, and of course she never wakes up. Based on the evidence from the inquest and from Professor Harmer's report, the lead anaesthetist, if I can call him that, in his own words, lost control. There was a question mark in the inquest about who people felt was in charge at different points. There was certainly a loss of awareness, an awareness of time, but also an awareness of the seriousness of the situation. If you like, the awareness of what was happening wasn't shared by each of the consultants. there was certainly a breakdown in the decision-making processes, and it would appear that the communication processes dried up amongst the consultants. The story with the nurses is very different. The nurses were generally aware of what was happening and what needed to happen. When I said to you that 6 to 8 minutes in, those 3 nurses arrived, one of them asked her colleague to go and fetch the tracheostomy set. There was already a quick trachea kit in theatre. She went out, she collected the tracheostomy set, she came back in, she announced to the consultants that the tracheostomy set was available, and there was no response. One of the other nurses who walked in immediately saw Elaine's colour, immediately saw the vital signs, and walked out again to phone intensive care. She phoned to check that a bed was immediately available. She came back in and she announced to the 3 consultants that a bed was available in intensive care. Cancelled that bed. At the inquest, 2 of the 4 nurses stated that they knew exactly what needed to happen, but again, to quote from the inquest, didn't know how to broach the subject. We have a breakdown of leadership, of situational awareness, of prioritisation, of decision-making, of communication, and of assertiveness. And these same factors, these same human factors, ironically, are present in 75% of aviation accidents. And really, since then, I've been trying to understand why in aviation we train and to understand about human factors, and it's an integral part of how we design equipment and how we manage procedures and how we work day to day. It's part of our everyday language, but I'm trying to understand why that's not part of clinical practice. When we get out to the aircraft, there's a lot of technical jobs that need to be performed. There's the usual security checks of an empty aircraft. There's the safety checks, both of the outside. We have to do a walk around, making sure all the systems are functioning and that everything we require for flight is switched on or operating in the way it should. Having done all the preparation, got everything ready for flight, we then get together in a briefing. And that's really to make sure that we both know what we expect to happen, but more importantly, that we think through all the possibilities. Up to 100 knots, you'll consider stopping for any ECAM warning or caution. Above 100, you'll only consider stopping ECAM warning, engine failure, something you think will stop us flying. 3 things to remind me of. With a positive climb, we'll get the gear up if appropriate. Remind me that TOGA's available. Remind me that autopilot's available. If it's not performance limiting, I propose to follow the SID. The only other exception to that is if we had some uncontrollable situation like the fire still burning when we get to S speed, in which case I'll pull that and it's suitable for a right-hand visual back to 27 right today. Any questions on the emergencies? Okay, as far as the departure, it's an opening up of communication. Human factors tells us that actually we're all wrong no matter how good we are, and we need people around us to help us. It's creating that open environment within your colleagues, being open to suggestions. If they put their hand up and say, excuse me, I'm not sure about this, it's not turning around and saying, actually, I'm the boss. And all of them will be much better clinicians as a result of what happened. That there's no doubt. The key message I would emphasise is that in aviation we know 75% of accidents are caused by human factors. In healthcare, what's the statistic? Is it 75% as well? Is it 85%? Is it 55%? No one really knows. My argument is, though, that the actual statistic is irrelevant. If you accept common sense and look around you, that tells you a large proportion of accidents and incidents will be caused by human factors. The lessons from other industries are there, and they're equally applicable to healthcare. And if it is only 45%, that is an awful lot of lives that we could be saving. Let's wake up to human factors. Let's make a difference.
Thank you very much.
Thank you so much, Agnes. There were some problems with the second video, so we will upload the full version of the second video on our website together with the recording of this webinar. So for anybody who would like to to view this again without any interruptions. Thank you so much, Agnès, for this fantastic and very interactive presentation. We do have a number of questions that are coming up, and because we're running out of time, we'll try to answer at least a few of them. And the first one is coming from Dina, and she's asking, Dina Barodi, and she's asking what the WHO did as regards to production pressure that healthcare suffered.
What WHO has done to production pressure?
Yeah, yeah, exactly. What the WHO
we haven't issued any recommendations on that. This is a very straightforward answer.
No problem at all. Thank you so much.
Sorry about that, but we will consider it.
Thank you so much. And the next question would be from Ilham Ochi, and he asks, how can you start a conversation on human factors, especially in an environment that relies so much on memory and associates one's ability to memory recall as a basis for intelligence?
Mm-hmm. So what is the question?
So how can you start a conversation on human factors, especially in an environment when they rely only on memory, not on a checklist or anything like that? So basically, Ilham is asking that what do you do in the hospitals that you don't have the procedures? You don't, as far as I understand, that is the question.
Mm-hmm. Okay, I understand. So I think the aim of all this is to try and have protocols in place, procedures in place, checklists in place. WHO has, and not just WHO, but all the other patient safety agencies around the world, ISQua, HRQ, National Patient Safety Institute Foundation, what have you, Australia, USA, they have been issuing and disseminating globally protocols, standards, standardization protocols, checklists. I think what hospitals have to do is to try and incorporate as much of this as possible within their settings. The leaders, the chiefs of departments, they have to bring these checklists and protocols that help memory and therefore make the working life of healthcare providers easier and much more focus on the tasks that they have to do instead of relying on memory.
Thank you so much, Agnès. Another question from Upasana Arora, and she is asking, just basically to expand maybe what you have said, and she's asking, can checklists prevent us from errors?
No, they cannot prevent, but they can minimize. We know that from the WHO surgical safety checklist and the evidence that comes from the implementation. It certainly lowers when it's implemented, it lowers the incidence of complications and prevents deaths by 30% and 33%, 20% and 33%. Sorry, the numbers I got wrong. But nevertheless, it does not prevent. It minimizes. It reduces the risk of error.
Perfect, thank you. There is another challenging question from Ilham, and it's quite interesting though. He's asking, sometimes I believe the safety record in aviation is overhyped. Recently, there have been a number of aviation accidents with hundreds of fatalities. More notably is the Malaysian Airlines, and he's asking, what are your thoughts about it?
Right, yes, very, very good thought, very good question, and very timely. Because if we look, we've had two really bad, or one really, the first Malaysian, the UB, I think 370, that was lost over the Indian Ocean, because the second one was, it was bombed down. And we've had so much media attention and articles for months on end because one jumbo jet crashed. Now, if we take the numbers, if we take the IOM report that quotes 100,000 deaths per year, and if we add 100,000 deaths due to healthcare-associated infection, these are numbers that are based on evidence and research studies. And we do a quick calculation, very quick math, we see that this is equivalent to about 15 jumbo jets crashing every week. Now, can you see the difference between one jumbo jet, Malaysian Airlines, crashing, and then the whole world talks about it for months on end? Yet, in healthcare systems, in every country, we have about a minimum of 10, 15 jumbo jets crashing, and nobody's saying anything about it. I think this is the interesting point here.
Thank you. A very good answer. We'll just have time for probably for one or two questions, and the next question is from John. He's saying, does providing incentives for performance has any role in addressing human performance factors?
I think incentives are very important, and yes, we should apply incentives, but I don't know the evidence on that. But I could find it and let him know.
Okay, and I think that would be the last question from Ada Costarelli, and she's thanking you for a very interesting presentation. She's saying, would you agree on the other hand that over-dependence on checklists might also result in decisions that are too restrictive and the skilling stuff? Fatigue would seem inevitable unless we allow for a reduction of productivity of healthcare staff. Can fatigue management techniques play a role? Or a small one, of course?
This is a very, it's a big question, isn't it? It contains a lot of different components. With the checklist, I think we can go with the evidence that it does prevent complications and deaths and injuries. But the hospitals have to take a checklist and adapt it to their own needs, their own situations, their own cultures. So in a sense, a checklist is a tool that is adaptable for any situation. With regards to fatigue, there are laws and regulations. I'm not sure that I've understood the question correctly, but there's laws and regulations in different countries and within facilities in order to prevent fatigue from taking place, well, or healthcare providers getting very, very tired. And for example, in Switzerland and other places in Europe, there is a certain working hours that nurses can do, and they cannot do any more working hours. I think it's 40 per week or something to that extent. I'm not sure if I've answered the question. If not, I'm very happy to discuss this issue with the caller over email.
Perfect. Thank you so much. We do have a number of questions, and I was wondering if we can send you those questions and maybe you can respond to some of them. I think there are around maybe 8 questions left, and we are running out of time. So I would really appreciate if you can respond to some of them, Agnès.
Of course, with pleasure. I can do that over email, no problem.
No problem. Thank you so much. Just to remind everybody that the recording of this webinar will be available on ISQua website within 24 hours from the date of the live recording. So please pass the information to anybody who might benefit from the information in this webinar. Please also note that the fellowship program participants who attended the live webinar would be automatically able to claim 2 credit points for taking part. And for the participants who are going to view the recording at the later stage, they will have to answer the compulsory question after the webinar to enable them to claim those credit points. I would like to congratulate Agnès on this magnificent and very interactive session. We are absolutely honored to have you with us today. I would also like to thank all attendees for joining us as well. And the last thing that I would like to mention today is to improve the quality of our webinar, we would greatly appreciate if you could also fill in the post-webinar 2-minute survey. Thank you to everybody again. Thank you, Agnès. Have a good day and goodbye.
Thank you. Goodbye, everyone. Thank you, Juliana.